Hello, everyone. This is Maeve from Eco International Marketing Team, and I welcome our participants from England, Ireland, India, Sri Lanka, Bangladesh, Nepal, and other countries to join in our webinar. And now we can see our lecturers are here, Professor Dengke Teng and Professor Guoqing Sui. And this webinar is organized by Eco Medical Company and regarding to their rich experience in the field of microwave ablation. So it's our great pleasure to invite Professor Dengke Teng and Professor Guoqing Sui from Ultrasonic Department of China, Japan, Union Hospital of Jinin University to give their presentations to our participants. And before our webinar, I want to give a very brief introduction about Eco Company and our lectures. And Eco was established in 2000, and its headquarters is in Nanjing City, which is very close to Shanghai. And Eco now has been dedicated to R&D, manufacturing, and marketing of microwave ablation products for many years. Eco has been working closely with ablation-related academic associations and experts across the globe to promote ablation technology. And now we have more than 700 employees operating in 35 branches and offices across the world. And the CCMA is short for China Conference on Microwave Ablation. It's an international platform for academic exchange and multi-party cooperation in the field of ablation. So, and with the initiative of Eco experts from ablation field at home and abroad, widely supported, formed, and organized this international forum. So, on behalf of Eco Company and the CCMA, I'd like to thank you all for joining our webinar tonight. And now I want to give a brief introduction about our lectures. First, Professor Dengke Teng, Deputy Chief Physician, Doctor of Medicine, Master Supervisor, Youth Committee Member of Ultrasound Branch of Chinese Medical Doctor Association, Youth Member of Ultrasound Intervention Youth Committee of Chinese Interventional Physicians Association, Youth Member of Tumor Interventional Committee of Chinese Research Hospital Association. And Professor Teng has been invited to serve as a reviewer for European Radiology, Endocrine, Journal of Endocrinological Investigation, and other journals. And since his work, Professor Teng has been engaged in interventional ultrasound diagnosis and treatment for a long time, and is good at interventional treatment of cysts, abscesses, and tumors, and especially in the thermal ablation treatment of solid tumors such as thyroid, breast, liver, kidney, uterus, and etc. And in recent years, he has presided over 4 projects and participated in 2 projects with public and government-sponsored research funds, and published more than 10 papers, including 7 SCI papers. Thanks, Professor Teng. Thank you for joining us. And for the introduction of Professor Guoqing Sui, Deputy Chief Physician, Doctor of Medicine, Doctoral Supervisor, Youth Committee Member of Ultrasound Medicine Branch of Chinese Medical Association, Youth Member of the Superficial and Peripheral Vascular Professional Committee of the Chinese Association of Ultrasound in Medicine and Engineering, Member of the Thyroid Group of the Ultrasound Therapy Professional Committee of the Chinese Anti-Cancer Association. And Professor Sui has been engaged in ultrasound diagnosis and interventional therapy for more than 10 years, good at ultrasound and the CUS diagnosis and interventional treatment of tricky cases. He has rich clinical experience in the ablation of solid tumors such as thyroid, breast, parathyroid, liver, kidney, uterus, and etc., and has taken the lead in developing new technologies such as microwave ablation of secondary hyperparathyroidism under ultrasound guidance and microwave ablation of peripheral lung cancer in the province. And he has presided over 1 project with commercial research funds and published more than 20 papers, including 6 SCI papers. Thanks, Professor Sui. Thank you to join us. And according to the course agenda tonight, Professor Teng will give us a lecture about the uterus microwave ablation first. And after Professor Teng's introduction, we will have a Q&A session. So if our participants have some questions, please leave a message in our chat box, and Professor Teng will answer those questions. And by the way, because we only have 15 minutes for the Q&A session, so Professor Teng will answer those questions in order that you have asked. And now, welcome Professor Dengke Teng to start his lecture. Professor Teng, now you can start.
Okay. Hello everyone. I'm Dr. Teng Dengke from Department of Ultrasound, China Japan Uni Hospital of Jilin University. It is my great honor to receive the invitation today to introduce something about microwave ablation for uterine fibroids. Uterine fibroids are the most common benign tumor in women of reproductive age, with an incidence of about 20% to 25%. About 20% accompanied by menorrhage, anemia, compression, and other symptoms. In the past, surgery was often used to treatment hysterectomy. There are many ways to treat uterine fibroids, and the surgical methods include laparotomy, laparoscopic, and hysterectomy. No surgical methods include catheter uterine artery embolization, transvaginal radiofrequency autocoagulation, knife ablation, high intensity focused ultrasound, percutaneous microwave ablation, and chemical ablation. Transcatheter uterine artery embolization. Most fibrils are supplied by arteries, but sometimes it is very difficult to accurately select the supplying artery of uterine fibroids for embolization. Affect ovarian function and subsequent pregnancy. Transvaginal radiofrequency autocoagulation knife ablation. This is minimally invasive treatment, but prone to be bleeding, pain, infection, intestinal damage, and other complications. Moreover, this method has limited therapeutic effect on large fibroids, subserosal fibroids, and multiple fibroids. High-intensity focused ultrasound. High-intensity focused ultrasound is helpful. Is a rapid developed no-invasive treatment technology in recent years. And in 2002, the first study reported the successful application of focused ultrasound in treatment of uterine fibroids. It is to aggregate ultrasonic energy to form a high energy focus to act on the target tissue, product coagulation necrosis, and achieve the purpose of treatment. The advantage of HIFU, less trauma, no damage to the skin surface, but it also have disadvantages. Long ablation time, sometimes unsatisfactory effect on blood-rich tumor or large tumor. Microwave ablation, ultrasound-guided percutaneous microwave ablation therapy, is an in situ inactivation technique for lesions. Using the local pyrogenic effect of microwave, it causes irreversible coagulation and necrosis of tissue cells, and realize the therapeutic purpose of in situ inactivation of uterine fibroids tissue and cells on the basis of uterine preservation. After that, the fibroids gradually shrink or completely disappear, or excretion through the vagina. How to use microwave to treat uterine fibroids? In 2017, the experts in China product percutaneous microwave or radiofrequency ablation for uterine fibroids clinical guideline. In the guideline, indications, contraindications, as well as specific operation procedures are introduced in detail. First, let's see the indications. Patients who meet all of the following conditions: uterine fibroids diagnosed by MRI or ultrasound. The FIGO classification is 0 to 6. Have any one of the symptoms such as menorrhea, secondary anemia, abdominal pain, compression, and so on. Patients have no signs of perimenopause. There is a safe trans-abdominal wall puncture path. This is the FIGO classifies uterine fibroids into different types. Type 0 to 6 is suitable for microwave ablation. Now, let's see the contraindications. Malignant lesions of the uterus, FIGO 7 type. There is no safe percutaneous puncture path. Uncontrollable acute pelvic inflammation. Dysfunction of important organs such as liver and kidney. Severe coagulation dysfunction. One is the appropriate timing of treatment. Treatment should avoid premature period, menstruation, and ovulation. Preferably about 3 days of clean menstruation before ovulation or after ovulation and within 1 week before menstruation. Methods of anesthesia. Intravenous anesthesia. Deep and heavy breathing may occur, which can affect the operation. If necessary, intravenous conscious sedation can be used for pain relief. Epidural anesthesia. Muscle tension, difficult compression, or not conducive to operation. Local infiltration anesthesia. Patients may experience fear and tension, and this method is suitable for smaller myomas. Preparation for before treatment, history taking and informed consent, including history of uterine irregular bleeding, history of pelvic surgery, history of infection, diabetes, hypertension, taking anticoagulants, pacemaker, malignant tumors, and so on. Patients are informed in detail about percutaneous microwave ablation treatment, advanced and disadvantaged, expected efficacy, potential complications and side effects, and other treatments available. Pre-treatment examination. It is recommended to perform cervical fluid-based thin layer cytology, chest X-ray, pelvic MRI, pelvic ultrasound, blood, urine stool routing, blood biochemical examination, coagulation function, electrocardiogram, blood CA125 and CA199. If there is an intrauterine device, which means IUD, it needs to be removed, and the treatment is carried out after anti-inflammatory and hemostatic sign relevant medical documents. Fasting water for 6 hours before treatment. Patients with severe constipation can take laxatives to guide and cleanse the intestine. Urinary catheter inserts half an hour before treatment. Patients with submucosal fibroids can be stuffed into the patient's vagina with 2 to 3 large yarn balls soaked in cold saline before the start of treatment to prevent microwave hot bubbles from flowing out of the vagina in ablation and scalding the vaginal mucosa, and also facilitate the observation of vaginal bleeding immediately after surgery. Before the ablation antenna to insert, artificial peritoneal effusion and ultrasound guidance was performed to form a solution belt around the uterus and the fibroids to prevent the intestine, ovaries, and other important organs from burning. Treatment procedure. Ultrasound scan of the lower abdomen is performed to select, locate, and determine the puncture site. In principle, the skin is chosen to be the closest route to the lesion, and the entry point is at the center of the lesion. The bladder, intestine, omentum, large blood vessel, and endometrium should be avoided as much as possible on the puncture approach. Contrast enhanced ultrasound, which was CEUS, was performed to evaluate the status of the blood supply of the lesion, and the images were taken to evaluate the effect after ablation. Routine skin disinfection, anesthesia, make 2 millimeter pinhole at the puncture site. Ultrasound-guided placement of the antenna with power and timing determined by location and size of the lesion. Deep to superficial, layer by layer moving ablation for large tumor. The ablation effect is evaluated at the end of the ablation. CUS is performed after the cessation of microwave ablation. If there is still contrast perfusion in the proposed ablation target, additional ablation should be performed immediately. Post-treatment precautions. At the end of ablation, confirm that the microwave has stopped. Remove the microwave antenna. Clean the skin of the puncture site and apply pressure to the skin. Remove the gauze ball from the vagina and observe for bleeding. Observe the color of urine flow from the catheter. The urinary catheter can be removed after the observer's vital signs are stable. And the anesthesia is sufficiently awake. The patient was observed to be able to eat liquid diet 6 hours after no special treatment. Follow-up observation is still required for 1 week after ablation. Delayed onset of the intestinal injury is usually symptomatic during this period. Ablation effect evaluation. Evaluation methods, CUS and enhanced MRI was used to evaluate the extent of ablation. The ablation rate was evaluated by percentage of necrotic area to the volume of fibroids before ablation. Evaluation index. Completely ablation, the volume of no perfused area accounted for more than 80% of the total volume of fibroids within 1 day after ablation. Mostly ablation, the volume of the no perfused area can account for 60 to 79% of the total volume of the fibroids after ablation. Partial ablation, 20% to 59% of the total volume of fibroid is no perfused after ablation. Ineffective, the volume of the no perfused area after ablation is less than 19% of the volume of the lesion before treatment. Evaluation of clinical effectiveness. Evaluation index. Fibroid volume reduction rate is recommended. This is the VRR. First, highly significant treatment effect. VRR more than 50%, 3 months after ablation. Significant treatment effect. VRR less than 49%, but more than 30%. Effective treatment. We are less than 29%, but more than 10%. ineffective treatment, which are less than 10% 3 months after ablation. In addition, hemoglobin symptom score and quality of life score can also be used as reference index for efficacy evaluation. Complications, prevention and management. About less than 10% of patients experience localized pain in the ablation area within 8 hours after treatment, which was tolerated by most patients and resolved on its own within 8 hours. No medication was needed, but some patients require symptomatic treatment. Vaginal drainage. After ablation of submucosal fibroids, patients may experience vaginal drainage, which is light pink in color and usually disappears on its own within 1 or 2 weeks. Prevention. Try not to damage the endometrium during puncture and ablation treatment. Vaginal mucosal burns. The incidence is due to heat flow along the uterine cavity and into the vagina as a result of the thermal field in close proximity to the endometrium. During the ablation procedure, prevention, a few large sterile gauze balls soaked in cold saline can be inserted into the vaginal before ablation to completely eliminate vaginal mucosal vaginal mucosal burns by the ablation. 4. Nausea. Nausea and even vomiting may occur in real patients after anesthesia. It can be treatment symptomatically. Prevention. Minimize the duration of anesthesia. Prepare adequately before treatment. Infection. Infection of the uterine cavity or treatment area is associated with the use of intrauterine device such as IUDs and intrauterine contrast catheters without strict sterilization during treatment or with poor local vaginal hygiene. After treatment, prevention. Strictly control the aseptic, invasive intrauterine operations and check the vaginal cleanliness beforehand if intrauterine catheter are needed. After ablation, antibiotics should be used to prevent infection. After treatment, patients should avoid sexual intercourse and public bath for 1 month. Intestine injury. Small intestine thermal injury requires surgical management. The incidence of intestinal injury is related to the pregnancy of the ablation technique and the indications. The majority of cases occur when the number of treatment cases is less than 30. Prevention: strictly follow the indications. Avoid passing through the intestine by punctured route. For benign lesions, complete ablation of fibroids should not be pursued if it is not safe. And the aim of the treatment is to reduce or eliminate clinical symptoms. For patients who have undergone myomectomy and have pelvic adhesions, artificial peritoneal fluid can be created before ablation. After the treatment, close observation and prompt anti-inflammatory treatment and surgical management are indicated if there is evidence of direct thermal injury of the intestine. Severe abdominal pain due to incomplete discharge of necrotic fibroid tissue through the cervix. Some of the necrotic fibroids tissue may be discharged through the vagina before or after ablation treatment, and when the discharged fibroid tissue is larger than the cervical opening, it may be block the cervical opening and cause severe abdominal pain like labor. The necrotic tissue is removed under direct vaginal vision. Antibiotics should be used to prevent infection during the discharge of a large amount of necrotic tissue. Let's see follow-up after ablation. It is recommended to review pelvic ultrasound, 6 analogical endocrinology, uterine fibroid symptom scores, and the quality of life relief scores, 3, 6, 9, and 20 months after ablation treatment, and every month after 12 months. During follow-up can be terminated if the fibroids are completely excreted or fibroids are completely gone. Now let's see some cases. This is a young woman. The main symptoms for larger menstrual volume, longer duration, ultrasound showed compression of the endometrium by posterior. Before the operation, CUS contrast enhanced ultrasound was performed. Let's see the video. We can see on the video this lesion is a rich blood supply tumor. And the intraoperative, we gave a 60-watt power ablation and 5 minutes of ablation. This is the intraoperative. Here is the antenna. After the ablation, we perform another CUS. On the CUS, we can see that the tumor was completely destroyed, and there was no no agent in the tumor. Let's see this case. This is a patient, 42 years old female with fibroids on the posterior wall, or the posterior wall of the uterus. Here is the size of the fibroids. 8.6 multiplied by 6.1, and the volume is 202 cubic centimeter. Before the operation, we start CUS. We can see that the tumor is not very full of blood. This is the intra-operation. Let's see the video. Here is the antenna. We can see that antenna was inserted into the tumor. And here the unecho area around the uterus is the artificial ascites that we ablated before surgery. When we start the ablation, we could see that the periphery of the ablation electrode appear hyperechoic around the antenna. After this area was treatment, we insert with another direction to ablate other field. It's about layer by layer, layer by layer. Because uterine fibroids often have pseudocapsule, the heat energy generated by ablation is generally confined to the fibroids so as to obtain a better ablation effect. Now, here is also the artificial ascites. Artificial ascites. Here we can see here is anechoic area. After the ablation, we can see there is no perfused of agent in the CUS. This is a complete inactivation of the fibroids. Post-operative MRI follow-up shows the uterine fibroids gradually shrinked. Here is the fibroids shrinked in 3 months after surgery. This is 6 months after surgery. This is the case that this patient is 42 years female with 2 uterine fibroids. The fibroids is not very big, it's very small. Now we can see the puncture antenna. From this direction. Here is the fluid, is the artificial ascites. You can see the antenna here, yes. Now, the antenna is inserted in the tumor, and we start the ablation. This area was hyperechoic. For the small tumor ablation, fixed ablation is enough. It's needed to use moving short ablation. After treatment, we perform CUS. The CUS revealed completely inactivation of uterine fibroids after microwave ablation. Here is the fibroids. This patient is a 43 years old female with fibroids on the posterior wall of the uterus, 12.1 multiplied by 9.9 centimeter in size, and 474 cubic centimeters in volume. It's a very big uterine fibroids. Before the microwave ablation, we perform a contrast enhanced ultrasound. The whole area is the tumor. Now we can see there is full of blood supply, rich blood supply. For rich blood supply tumor, we usually need more energy to destroy the tumor. And for poor blood supply tumor, we need less energy to destroy the tumor. So the CUS before ablation is very important. For the last fibroids, layer by layer multiple point ablation is required. First, we insert the antenna in the deep area and start the ablation. And then we pull the antenna out. After ablation, the deeper area. We pull the antenna out and ablate the ablate this area. After this insert, we change the direction of the antenna to another direction, and also first destroy the deeper area, and after that, this layer may be destroyed completely. Then we change the layer to destroy another layer. For large uterus fibroids, it usually needs more times to the operation, for the operation. And for the large tumor, the CUS after the ablation is more important to find the alive area immediately, and then we can destroy this area. After the ablation, a CUS also performed. This patient we treat about 2 hours to complete the ablation. And then we achieve a very good effect. You can see most of the fibroids are destroyed and no agent in the fibroids. Okay, then 3 months after the microwave ablation, the volume reduction rate of the fibroids is 59%. Three months after the treatment, CUS shows that the lesion volume was significantly reduced, and the ablation area did not perfuse with contrast agent. This is a 39-year-old female with fibroids on the posterior wall of the uterus, bulging outward to 5.2 multiple by 5.0 centimeter in size. The uterus is horizontal position, so the normal puncture may pass through the endometrium and cause endometrial damage. So we use a urine lifter to lift the uterus and create a safe puncture path through the bottom of the uterus. Here is the uterus lifter, and we insert the antenna from the bottom of the uterus and destroyed the fibroids. And our antenna did not cross the endometrium. This is a patient, about 38-year-old female with adenomyomas. Here is the tumor. Here's the tumor. Pre-operation CUS could see that this was a lesion with raised blood supply, and could see the contour of the lesion. And the contour of the lesion is very clear under the CUS. Here is the CNB. We perform a colon needle biopsy to confirm that this is a adenomyomas. This is the first process of the microwave ablation. You can see we inserted the antenna very fast because the fibroids was tough, very tough, hard to insert. So we need to insert the antenna harder and faster to make sure the direction was not changed. And an iconic area around the fibroids is the fluid. Artificial ascites. CUS reviewed. Let's see the CUS. Most fibroids are not perfused immediately and 1 week after ablation. This is the immediately, and this is 1 week after ablation. Now let's see some tips about microwave ablation for uterine fibroids. In addition to helping reduce the risk, the establishment of artificial ascites can also reduce post-operative pain. Due to the tough texture of uterine fibroids and large uterine mobility, in order to avoid deviation during puncture. The ablation antenna need to be aligned with the direction and enter quickly, or an ordinary needle can be inserted to fix the uterus, and then the antenna is punctured. Because the uterus may be deflected during puncture, the extent of fibroids should be reobserved after ablation. Fibroids located in posterior wall of the uterus can use a uterine lift to create a safe puncture path. Summary: thermoablation offers patients an alternative to open surgery or laparoscopy. Current evidence suggests that microwave ablation is safe and effective in the treatment of uterine fibroids. Although HIFU can be used to treat uterine fibroids non-invasively, its long-term shrinkage rate and long-term recurrence are sometimes unsatisfactory. In the future, more studies are needed to accumulate evidence on thermoablation of uterine fibroids. This is the article on microwave ablation for gained uterine fibroids, just published by our team this year. That's all. Thank you.
Thank you, Professor Teng. Thank you for your sharing about the indications, contraindications, precautions, and your case sharing. And now we have some questions. We have received some questions shared by our participants here. And because the time is limited, so we will invite Professor Teng to answer 3 questions in the order. And we have already screenshot all the questions. So after this webinar, we can send you all the answers. So Professor Teng, about the first question, what is the fertility situation after microwave ablation? 陈教授，就是在微波消融以后，这个关于女性她的一个生育状况大概是怎样的 ？Please.
This method is I think is helpful to prevent the function of female. But when we before the operation, we need to evaluate the position of the fibroids. If the tumor is near the endometrium, we need to very carefully for the ablation. But if the tumor is far away from the endometrium, it is very safe to prevent the function. For the lesions near the endometrium, it have 2 situations. If the patients want to save his function, we need to very carefully for the ablation, and we can leave a little fibroids which was near the endometrium. But if the patient is not very careful about this function, or some situations the patients have enough child and she doesn't want to have more child, we can ablate the tumor completely, and yes, that's all.
Thank you, Professor. And for another question, for the treatment of the large size of uterine fibroid, how many antennas should be used for the treatment? And if we can only use one antenna, and what is the power and the duration? 陈教授，就是关于就是大体积的这种子宫肌瘤，然后一般是要用多少根针呢？如果只用一根针的话，那这个关于时间还有效用的时间和功率上面是一个怎样的设置呢
？For large fibroids, it has two situations. If the patient is enrichment, we can have a routine operation for two antennas to insert into the fibroids to destroy the tumor, and it can be very fast and very efficient. But if the patient is not very rich, we need to save money for the patients. We usually use one antenna to treat the patients. In this situation, we need to ablate the tumor like thyroid tumors by layer by layer to destroy the tumor. And the power, we usually use 60 to 65 watt. The duration of the ablation, we usually 1 point to 1 or 2 minutes, and then we change the point another layer by layer, point by point, layer by layer, and many points to form a line, many line to form a layer, and many layer to form a ball, tumor. That's all.
Thank you. Thanks again, Professor Teng. Thank you for your detailed explanation. Thank you.